I've been talking more and more about it in recent weeks, and I'm seeing more and more cases. And I actually uploaded a video, I think it was yesterday's video, which discusses a canal cholesteatoma in more depth. But in brief, what a canal cholesteatoma is, it's a skin plug, a skin cyst, should I say, that's self-growing. And it creates a lesion in the ear canal, so an ulceration of the skin. This is on the bony part of the ear canal. It then infects the periosteo, which is a thin sheath that lines the bone, which supplies it with blood and nutrients the bone requires in order to sustain and not die. But when you have periosteoitis, an infection of the periosteo, the underlying bone is starved of all the blood and nutrients it requires, and it starts to die and decay, a process called necrosis, and then you get defragmentation of the bone, and that's the question. And this can then spread across the temporal bone. The temporal bone is the bone that encases the ear canal, and it can start invading adjacent structures, so the TMJ, the temporal mandibular jaw joint. It can go to the mastoid cavity, it can go towards the brain, and deep within the ear canal, through the eardrum, into the middle ear cleft, where it can sometimes affect the facial nerve. So they are very rare, one in 1,000 cases. I think it's underdiagnosed, though. I think the frequency that I'm seeing at the moment is much more than that. And I think the reason why it has gone up misdiagnosed in the past, because sometimes patients don't have symptoms sometimes. They are benign conditions, they can quite often be asymptomatic, but it can quite often be hidden by a layer of skin on the ear canal. And if that's not removed, it's obviously tucked away, unbeknown to the patient and the specialist. So this patient just cleared their left ear. They had a huge skin plug here. This is their better ear. They have got either eczema or psoriasis at the entrance of the ear canal, and that can lead to a higher turnover of skin. You get increased skin secretion and development, and as a result, subsequently, more dead skin cells in the ear. And a cholesteatoma is, as I said, it's a plug of keratinizing squamous epithelial skin. So this is their right ear, and you can see they've got a skin plug here and loads of keratin squames, so sheets of keratin, dead keratin. They visited the doctor who advised that it's not an infection, that it's just a bit of wax that needs to be removed. But I can understand why they may have believed that, but this is actually a dead skin plug, but also underneath. And so again, here on the way is a fungal infection, Otomycosis. And more specifically, Aspergillus. I don't know if it's Aspergillus niger or flavus. I've got a feeling it's Aspergillus flavus. It's just the colour of the fungal spores, they're a bit more yellow and green. Whereas Aspergillus niger, sometimes the fungal spores are more white and black. I mean, there's a few black ones. Sometimes you can get multiple strains of fungi. It could also be Candida. Now, you may have seen there the eardrum flex. As I was performing microsuction, the eardrum got attracted to the suction post, so the eardrum was being pulled inwards laterally, so we're just going to be a bit cautious here. They could hear significantly better already, and I'm just going to spend the next 10 minutes or so to try and get as much of this mushy fungal discharge of the ear canal and eardrum directly. It is probably the most difficult type of consistency of wax and infection to remove. It's very mushy and glutinous. I don't want it installing drops in the ear, because by introducing drops it can change the acidity of the ear and possibly promote further fungal growth. If you can't use water, water is probably the number one cause of infections in the ear canal. There's no other instruments you can use to remove it, so it's going to be patient, using a suction probe. Patients been several times over the years, so they're still very competent, they know what to expect. Now, this is the ear that I uncovered a canal cholesteatoma. They had multiple lesions and localized exposed bone. If memory serves me correct, they had one on the anterior inferior canal wall, which basically means the front part of the canal to the right and near to the bottom. So in terms of the compass, you're looking at southeast. I think they had one inferiorly, so south, and also one further back in the ear on the posterior canal wall about 7 o'clock, so looking at southwest. And referring to ENT by the GP, the patient initially went to see a specialist privately because of the waiting list, and at first it was unsure whether it was canal cholesteatoma or benign osteomycosis, because they're very different conditions in terms of the mechanism. Benign osteomycosis is due to poor vascular supply, and therefore the bone dies underneath the skin and it creates a crater. But the outlook, it looks very similar. Canal cholesteatoma is caused by dead skin in the ear canal itself, eroding the skin, ulcerating it and then decaying the bone. So it's a top-down mechanism of canal cholesteatoma is. Benign osteomycosis is the opposite way, and therefore the treatments are slightly different. If you've got benign osteomycosis, the idea is to re-vascularize the bony section, so quite often osteome is relocated to that region to provide more blood flow and blood supply, and hyperbaric chambers sometimes have been used as hyperbaric therapy, sometimes as a treatment method. Whereas with a canal cholesteatoma, the idea is to get rid of all that bone and put a graft in there, which can also be done in the case of a benign osteomycosis. You put a temporal fascious muscle graft, which is the top of your near temporal bone. You have like your jaw, when you pinch your jaw, you have your muscle that contracts higher up. So they take some fibrous tissue there, and sometimes even muscle. They patch up a crater caused by the pathology. So you're getting rid of that pothole. So this patient underwent a otomycosis with skin grafting and some fibrous muscle graft from the temporal fascious region, and the patient was obviously worried that the canal cholesteatoma had resurfaced. They had the surgery last June, and they are due their 1-year follow-up, but it's been delayed because of all the waiting lists. So we've managed to clear this today, and what was great is although my suspicions are that this patient's got a fungal infection, but you can see the spores, so I'm pretty sure it is, but I'm just going to make sure there's no concurrent bacterial infection as well. So I've just asked the patient to use some antifungal solutions, so Canesten, for example, in the UK, but prior to doing so, get an ear swab taken by their GP. If you use any drops prior to the swab, it can almost be contaminated by the drops. So they managed to get an appointment straight after seeing me on the way home with the doctors. They got really good doctors. They're a really good surgery. We heard great things about the surgery. And I had a swab taken literally on the way home from the clinic, and they won't go get the results next Friday. In the meantime, they are hopefully using some antifungal solution in the ear. So the ear's quite clear already, they can hear very well. Just want to get again as much of this out. I'm not going to get every last speck, and the ear is very sensitive. When we're working on the bony part of the ear canal, the eardrum itself, you saw right at the beginning with the full suction probe that it got attracted by the vacuum, and the eardrum was being pulled into the vacuum, so we have to be careful. And the eardrum is about 0.1 millimeters in thickness, it's wafer thin. With a fungal infection, you've got to be careful of thrombosis of the blood capillaries supplying the blood and the nutrients to the eardrum. It can occur with a fungal infection, which can then lead to perforation of the eardrum. The patient also suffers from eustachian tube dysfunction, and they regularly use the Otomycosis nasal balloon. So the eardrum actually does look a bit retracted posteriorly here to the right. It's just so difficult sometimes when it's you've got debris like this to fully visualise and inspect the eardrum, but it just looks slightly retracted. But they use the Otomycosis nasal balloon, which is a balloon you inflate using your nose, whilst blocking the contralateral nostril, closing the mouth. It traps the air into the back of the nose and nasopharynx, so that the eustachian tube connects from there to the back of the eardrum in the middle ear. And it forces air up the eustachian tube, so even if it's blocked, it at certain pressures the muscle, it causes the muscles to contract. The eustachian tube opens, the middle is ventilated, any fluid behind the eardrum will drain out. And if you have got negative middle ear pressure, the Otomycosis nasal balloon helps to equalise it. And they've been using it, I think, twice a week for the last 3 or 4 years since I met them, to really good effect. Now, this is, looking at all their notes, they have got a history of chronic ear infections, and that's possibly one of the reasons why they developed a canal toshitoma. It's a benign condition, it can be secondary to chronic ear infections. With this skin that's dying and decaying, it releases proteolytic enzymes which start to break down proteins into amino acids, and also lysosomal enzymes. They can cause trauma and ulceration to the skin. Now I was trying to look for their videos. I'm pretty sure I uploaded it back in around December 2021. I just couldn't find it for some reason, but I do remember uploading it. It was a very interesting case. So I'll have a look again, and if I can find it, I will in a specific video and provide details and links, and I will come back to this video and put the link in the description box. So just a bit of debris here. I'm probably nitpicking a bit here, but the patient was so still, and if I think the more fungal infection I can remove out, the better the opportunity is for the solutions that they're going to use, the antifungal solutions, to make contact with the eardrum and be beneficial. So it all depends on how still the patient is, how confident I feel. Sometimes patients are a bit unsteady, and will probably stop by now. Now they've got their myotoplasty, as I said, the patient's very happy to wear it. It's successful. I can't see any erosions there at the ear canal. So it all looks very well. And they have a brilliant surgeon as well, performing a lot of these procedures. So they're in safe hands. The patient advised that they've been using some olive oil drop prior to attending, and something I've discovered recently is if you've got a fungal infection, the introduction of olive oil into the ear can exacerbate the fungal infection. The fungi feed upon it, and it helps them to reproduce and exponentially grow in numbers. So I advise the patient to avoid any olive oil. The olive oil was also recommended because I do have this, as I said, eczema psoriasis. Also at the entrance of the ear canal, but no doubt there is some in the ear as well. And again, that just leads in a proliferation of skin cells, which eventually die, so there's just increased dead skin in the ear. So just a little bit left in freely. I'm going to go back and try and get it out. So again, guys, there is going to be some residual debris around here. I'm not going to get every little aspect, it's just not possible. I'm happy with what I've done already, truth be told. There we are, got that eardrum. It's all this residual stickiness now, but if you look at the before and after videos, you see the difference. So, eardrum's intact,